Good morning, everyone, or evening, depending on where you are in the world. I'm Bob Dempsey, and I have the honor of chairing the Foundation for International Education in Neurological Surgery. We have been dedicated to education at all levels for neurosurgery throughout the world, especially in areas where there has not been that in the past. One of the most important things we do is a virtual visiting professor program where we have one of our fellows introduce a luminary from around the world to speak on different topics. This is a way not only do we continue our education, but we bring our fellows together continually in postgraduate education. We're very honored today to have Sahara introduce Dr. Woodrow, who will be talking about spine and spine tumors, which is very important in the developing world. Dr. Woodrow will be doing a boot camp in Ethiopia in the next few months, and FEANS will be sending out information regarding this, as well as the fundraising for it. We're very pleased to have you all here, and I'd like Sahara to take the screen now to introduce Dr. Woodrow. Thank you.
Thank you, Professor Dempsey, for the introduction. My name is Dr. Saara Kasai. I'm an assistant professor of neurosurgery at Maqale University, which is in the northern part of Ethiopia. I'm honored to introduce Dr. Sarah Woodrow, and good morning and good evening to everyone, depending on where you are. So I would like to introduce Dr. Sarah Woodrow, who is currently an academic neurosurgeon at Cleveland Clinic, and she's a board certified neurosurgeon. She's a fellow of American Academy of Neurosurgeons. She's also a fellow of Royal College of Physicians and Surgeons of Canada. She specializes and she's specifically interested in complex spine surgery, minimally invasive spine surgery, robotic surgery, neurotrauma, and global neurosurgery and neuroeducation. I have had the honor of meeting Dr. Sarah back in the days when she visited us in Ethiopia. She's been a great ally of the Ethiopian Neurosurgical Society for over 15 years now. That's part of her global work, and she has helped us mentor neurosurgery residents. She has sponsored training, and she has also visited us on multiple occasions. So we are very happy for that for Dr. Woodrow. And with that, I open the floor for Dr. Woodrow to start her discussion. Thank you very much, and you can start.
Excellent. Thank you so much, everyone. Let me just share my screen, see where my button is to share my screen. Share, there we go. Okay, are we able to see the screen?
Yes.
Yes.
Perfect. Okay, well, thanks for the great introduction. When I chose this topic a while back, I thought I would have the usual hour to present, and I've heard Dr. Dempsey runs a tight ship with these presentations, so I've shortened the presentation a bit, but hope to give you kind of an overall perspective of spine and spinal cord tumors through a number of different ways. The plan really is to start with a broad overview. You know, I'm not going to sit here lecturing you on the different pathologies we see and the histologies and things like that. I think you can read most of that in the textbook. I will do a broad overview to start to give you an idea where we're going, just to put us all on the same page, and then really just dive into a series of cases to try and illustrate some teaching points that I think are really important and the complexity of decision-making in this particular subspecialty. Just before we start, there's going to be a little test for you guys watching. So I'm trying to make this a little bit interactive, which is always a bit of a challenge in virtual professorships, but there'll be a few times during the presentation, I may ask the audience if this is someone you would operate on or not. And what I'd like you to do is just go into the chat and either put in the thumbs up or the thumbs down. And Sahara is going to try and monitor the chat for me and give me an indication of whether people would or wouldn't in general operate on this patient. And then I'm going to do one other thing. I'm going to see if we can participate a slightly different way. And what I want you to do, let me see. Well, that's not working, so never mind. I'm going to try during the course to ask the audience a series of questions, and there should be a barcode that goes up. Hopefully this will work. For those of you who have smartphones, if you if you click on the barcode, it should direct you to a site, and you should be able to answer, and we can see the audience. We can poll the audience in real time. It may work, it may not, but we'll try it. Okay. So spinal tumors. Most of you are familiar with this sort of general classification of spinal tumors. When we talk about spinal tumors, we predominantly talk about intradural versus extradural tumors. In terms of extradural tumors, you can categorize them based on their aggressiveness. So benign tumors such as hemangiomas, osteoid osteomas, osteochondromas, ones that originate from the bone or cartilage, as well as ones that then originate from the soft tissues around. So schwannomas, for example, are more benign lesions. We see sometimes non-neoplastic cysts, so synovial cysts, also another one. On the malignant side, metastases, in my practice, is by far and away the most common type of bony tumor I see, but we also see a lot of hematological malignancies, such as multiple myeloma, lymphoma, as well as much less commonly primary malignant tumors, osteosarcomas, osteochordomas, chondrosarcomas. On the intradural side, again, we're thinking compartments here in terms of trying to classify the extradural versus the intradural. On the intradural side, ependymomas, astrocytomas, hemangioblastomas are the more common things, although we do occasionally see metastatic lesions that go intradurally. And then sometimes we have mimickers, inflammatory conditions like MS, sarcoid, that look like intramedullary tumors that are in fact not. So we have to keep that in mind. On the extramedullary side, again, think of the soft tissues structures that we see within the dura, but extramedullary meningiomas, schwannomas, myxopapillary ependymomas are kind of three top ones that we see, but there are a number of other ones that can also appear there. When we talk about patient presentations for these tumors, in general, when patients present, some are incidental findings, but most have some sort of symptomatology. And generally, pain and neurological symptoms are the two things that bring them in, and often there's some overlap there. But as you're trying to figure out what's going on with the patient, then there's other points that are worth considering. You know, their medical history. Do they have a known history of cancer? Is there a family history of cancer? What's the time course of the symptoms? Have they been festering along for months and months and months that may be more suggestive of a more benign process, or has it been rapidly progressing? And then the location of the pain or the neurological symptoms also help to focus us. When we talk about pain specifically in these patients, we tend to talk about three different syndromes that occur in relation to spinal tumors: biological pain, mechanical pain, and then radiculopathies. So biological pain is the type of pain that's really a result of the tumor itself. And we believe it's inflammatory mediated. And we know this because typically these patients present with morning pain. So overnight, when your adrenals stop working, your cortisol levels plummet, then inflammation goes up. These tumors tend to hurt. You wake up in the morning with a lot of pain, and then as the adrenal glands kick in and your cortisol levels go up, then the inflammation settles down and you feel better over the course of the day. And it's a cycle. And patients often come in complaining of nocturnal pain, of early morning pain. And these are tumors that respond well to steroids as a result, because they're inflammatory mediated markers that are causing the pain. Confounding this is what I call dural pain. So just a quick refresher on our microanatomy here. So the dura throughout the spine is innervated by pain sensors, and the meningeal nerve comes off of the nerve root just past the dorsal root ganglion as the anterior and posterior rami divide. And so at every single level of the spine, you're going to get a pain response. And so if you've got pressure on the dura from an epidural tumor, if you've got pressure on the dura from an intradural tumor, they're going to cause some baseline pain that's going to be there more constantly. Mechanical pain is another type of pain we see commonly in spinal tumors. And this is the pain they refer to as movement-related pain due to the bone pathology that's there. And sometimes the type of pain, the description of the pain can help you identify that. So for example, if a patient's got tumors up at the C1, C2 junction, you'll often complain of pain on rotation. If a patient's got a burst fracture in the thoracic spine, they've kind of settled down into a bit more of a kyphosis than normal, but they're comfortable in that position. So when they go to lie down at night, They can't stand the pain. It really causes them a lot of distress, and they'll even sleep sitting up. So when patients come into your clinics describing these types of patterns, again, it kind of tweak you to what may be going on. And there's some suggestion with all of these that there may be some inherent instability in the tumors as a result. And finally, radiculopathies. So usually radiculopathies, as we know from degenerative disc disease, is a result of foraminal compromise and pressure on the nerves. Sometimes these can be mechanical radiculopathies, whereby you've got a burst fracture, such you see in the picture here on the lower right side of the screen. With the burst fracture, there's some compromise of the foramina, and then when you have the patient extend back, that foramina closes up even more, and then you've got even more pain. Or there can be constant pain there because the tumor's all infiltrating around the nerve root and the foramina and causing ongoing pain. But you have to be cautious in these cancer patients that there can be mimickers. For example, an L2 radiculopathy goes to the groin region. Well, so does a hip problem. And patients who have metastatic disease can have METs everywhere, including in the hip and maybe an occult fracture. So again, just because they've got what sounds to you like an L2 radiculopathy, you have to keep your mind open. And typically these radiculopathies present with pain, but certainly they can also present with motor and sensory symptoms as well. Which leads me nicely into the neurological symptoms. So the things we most worry about as neurosurgeons and spine tumors is compromise of the canal. And this can come intradurally when you've got tumors that reside within the thecal sac. And sometimes their location and their neurological symptoms match up nicely. Again, most commonly I see metastatic lesions, which often have a lot of epidural disease associated with it. Typically, metastatic lesions originate anteriorly in the body and then start expanding posteriorly. So you start getting pressure on the cord, again, anterior to posterior. So initially the spinal thalamic tracts are compromised, then the coracospinal, and then eventually the posterior column. So patients present, typically they complain of numbness, tingling, say in the legs for a period of time, and then they finally start noticing some weakness, and then their balance starts going off. And that's a pretty typical pattern that we see in these types of tumors. Radiology for tumors. So nowadays, we're fortunate that we have a lot of access to radiology, although in some places that a lot of you work in, I know that's not the case. Plain x-rays are a great place to start, but they're pretty limited. You know, if we see a fracture, a pathologic fracture, that's helpful. If we see, you know, the winking owl sign, loss of the pedicle, that gives us some hints, but they're going to be pretty limited in seeing anything that's going on within the canal. CT scan is a bit more common. Again, can give us some indication if there's some lytic lesions there. Excuse me. But really, MRI is kind of the standard in terms of being able to get a good understanding of the structures there, including the cord, the nerves, and whatnot, to give us an idea of what's actually going on. I'll just mention in passing dynamic contrast enhancing MRI, DCE MRI, sort of a newer technique that's being developed where it's a T1 image with timed contrast enhancement given, and it allows us to start distinguishing a little bit more what may or may not be active tumor. So for example, the picture on the left here is a patient who's got no metastatic disease, that's been very well controlled systemically, is having worse pain and has a number of different lesions through the spine. On the DCE picture that you see, you've got a nice bright spot that lights up right in the middle here. On the right side is another patient also with metastatic disease with some pathologic compression fractures. Also got a DCE scan, but there's a nice big void there suggesting there's no active disease. So imaging techniques that are constantly being developed can be very useful in trying to help us distinguish between active and passive disease. And likewise, bone scans, PET scans are also important to understand the systemic burden of these types of problems. So what's our role and what's the role of surgery in spine tumors? Well, I'd argue that most of my cranial partners kind of see me like this in my practice. They think I like to cut on bones, I like to put screws in, but don't give me a lot of credit for it. And certainly when I went into training, and one of the mantras that I often teach with is that I'm a simple spine surgeon. When I think about spinal disease, I think about neurological compromise, I think about structural compromise, and that's how I make my decisions. And certainly the goal of any kind of spine surgery is to improve or maintain a person's quality of life in terms of neurological function, in terms of pain control, as well as getting a diagnosis. But I'm going to argue to you over the next few minutes that I think this is a bit of an archaic view on what we do as spine surgeons. So stay tuned. So first case. So this is a 47-year-old gentleman, previously healthy, several week history of worsening back pain. He's ambulatory. He walks into the emergency room or your clinic, and he comes in complaining of a 2-day history of weakness in the lower extremity. He's just having difficulty moving his legs. He's had some tingling for a few days and then some weakness. His exam isn't terribly remarkable. He does have some weakness in the lower extremities. But it seems to be more just in the hip flexors and seems to be more pain limited than anything. His reflexes are normal. He's got 3 beats of clonus bilaterally in the lower extremities. No real clear sensory symptoms. Again, he complains of tingling that's kind of non-specific. He's been worked up on his way to you, so he comes in with this image, which clearly shows a lesion that seems to originate in the bone. I think that was T8. With some epidural extension. It enhances nicely. The axial views give you an idea of how much epidural disease there is, as well as some disease out on the left side here, outside the spine. So comes in with some pain, a little bit of weakness, and this set of imaging. So let's, first question I have for the audience, and see if people can put in the chat thumbs up or thumbs down. Who would offer this patient surgery? Who thinks this patient needs surgery? We'll see if anybody answers over the next 20 seconds. Is it working? Did anyone? Okay, I'm going to move on to the next thing if we're not sure.
I don't see
No
any responses in
comments
the
yet.
Q&A right now, but if anyone does want to, they can just even with the emoji, just do a thumbs up or thumbs down in the chat box in the Q&A section.
Okay. So unfortunately, my Slido is not working, so I apologize. It was working when I went through the test. So the next question was going to be for everyone, well, when would you operate? If you do decide you want to do surgery, is this a patient you would take to the operating room now at 4 o'clock in the morning, take them the next day, take them, whenever surgery is available later on in the week? Is this someone you would not operate on, that you want more of a workup on? Just think about those questions as I go through the cases. Unfortunately, it's not working. Sorry. Okay. I'm going to give you another case now to think about. And you'll see there are variations on the same theme. So this is actually pretty much the same case. 47-year-old, previously well, same history, several week history of worsening back pain with some weakness. Only comes in now with a slightly different exam. As opposed to having just a bit of pain-limited weakness in the hip flexors, he's actually got diffuse weakness throughout the lower extremities, not even anti-gravity, could not walk into the office or the emergency department, whatever the case may be. Does have a bit more subjective numbness for T10. Bowel bladder's intact. Same image. Still have some lesion around T8 with some epidural disease and a fair amount of pressure on the cord there. So same set of questions for everyone to consider. Would you operate? If so, when? Is it something you take at 4 o'clock in the morning in your environment? Is it the next day? Is it a week later? Is it never? Think about those things. Oh, I'm upset that we can't get these. It would have been fun to see what everyone was doing.
So two attendees have commented and they say they would operate on the time that the surgery is available.
Okay. That may be, I wonder if that's the first case or the second case. Also, I'll give a pause after this case and we can kind of potentially ask for more comments then. So third case, I call it case 1C because you're going to see this again, the same type of history here. So same patient, only in this case, this patient actually has history of a primary malignancy, of renal cell cancer that had been previously treated. So same back pain, some weakness in the lower extremities, This weakness is mild. It's like that first case. So some hip flexor weakness that's probably more pain limited, with a bit of clonus bilaterally in the lower extremities, but is generally generally well. So same set of questions for people to think about. So again, same image. Who would operate, and then when would you operate? Is it something you operate, again, middle of the night? Is it something that's done in a delayed fashion? And if so, why are you stopping? Okay. So the reason why I chose these three cases, and then three very realistic cases, one of them is the actual scenario of the patient, and the other two are variations that I've thrown in there, is to illustrate that decisions aren't quite so simple when you sit down and really reflect on them. There's a lot of things that go into that decision. So for example, in the first case, the patient comes in with some mild neurology, some pain, clearly has cord compromise, but has this epidural lesion. Well, the first question is, what is the lesion? Is it benign? Is it malignant? Just with the patient's history alone, you're more inclined to think, I think it's a more aggressive tumor, and certainly looking at the images, I'm concerned it's a more aggressive tumor. Is it a metastatic lesion? Is it a primary lesion, a hematological lesion? Does it represent a lymphoma, for example? And that's the type of process I go through as I'm looking at those cases. Next is, we need to figure this out. So we can run a metastatic workup. In this case, we found out it was negative. We can, if it's negative, then we're probably leaning towards a primary malignancy. If it's a primary malignancy, most likely probably a lymphoma with that picture. Well, if it's a lymphoma, is surgery something I should be doing on this patient? Well, we know that lymphomas are particularly radiosensitive, and there's other ways of treating them. So surgery, rushing into surgery at 4 o'clock in the morning may not be the right decision for that patient. He's got a bit of weakness. It's probably more subjective than clearly objective. We probably have a bit of time, but we have to make that hard call that we're going to wait, take our time, maybe do a biopsy and see what's going to happen. The next patient came in, same exact case, but now he's much worse neurologically. 4 o'clock in the morning, what are we going to do? And my tendency in that patient is, with that profound weakness, we need to get on this, and we need to get on this pretty quickly. If he's a young guy, he's well, that's probably a case that I'm not going to wait. I may not do it 4 o'clock in the morning, but I'm certainly not going to wait to do a full set of workup, which includes a biopsy, which typically would take, days, even in our institution, to get results back on. That's a patient that would probably go to surgery sooner rather than later to at least decompress the canal, do what we call separation surgery, make sure that the cord is nicely decompressed, knowing that if it is something that's radiosensitive and treated with other means, that they're going to go on to need that type of treatment. And then in the third case, the renal cell patient, well, we probably know what that disease is going to be. It's renal cell. But if it's renal cells, should we be operating? Should we just be radiating? Well, it's not a radiosensitive tumor. It's a radio-resistant tumor. So now we've got a patient with a lot of cord compression, radio-resistant tumor. Do we do surgery? What's the timing there? Do we take a chance? I would say in most institutions now, given that amount of cord compression, no one's going to be comfortable radiating a radio-resistant tumor with and expect a reasonable outcome there. And I think in that case, again, surgery is something that would be indicated, not necessarily that day or the next day, to set up the patient to do that separation surgery, give them some extra space there. Some people would even argue, do you need to instrument at the same time, and knowing that you're never going to fully adequately treat that disease, and then go on to eventually other treatments. So these are all kind of interesting and I think challenging decisions that we have to make with, again, very similar looking presentations. And my point with all that is making sure that we understand that treatment with a lot of these tumors doesn't stop, typo there, doesn't stop with surgery. It's not surgery alone. We're just a part of the puzzle there. And so getting back to what I was first talking about at the beginning, the role of surgery in spine tumor and my simplistic surgical mind, that thinks, well, normally for a trauma, it's a pretty easy decision. Is the patient neurologically stable? Is the patient structurally stable? And if the answer is no, then we probably have to do something. We have to fix it, and we've done the job and taken care of the patient. I would argue that as oncologists, as spinal oncologists, surgeons who undertake procedures for these types of lesions and the huge gamut of lesions, we're more than just surgeons. We have to think first as oncologists and then as surgeons. First, understanding the nature of the disease and what's in store for the patient, and then help that guide your decision making. If you're not familiar with the NOMS framework, I highly suggest you take a look at this paper or some of the other papers published in this area. But it's a framework that was published, I think, more than 10 years ago now from Sloan Kettering, and it really speaks to this point. It kind of gives us a bit of an algorithm in terms of what we could and should do with some of these patients. And it stresses that we're not just looking at the neurological condition of the patient and the mechanical stability, which is how we typically think of spine trauma, for example, but we have to think of the oncological burden. We have to think of systemic disease as part of this decision-making process. So, first of all, is there compromise of the epidural space? Is the patient myelopathic or not? So those are the neurological considerations. From an oncological perspective, is the tumor that the patient has radiosensitive or not? Or maybe it is, but it's been previously radiated. And that's going to bear weight in terms of, again, what treatment can the patient have down the road? In my renal cell case, it's a radio-resistant tumor, and that does change how aggressive I am on the surgical side. Mechanical stability, is the patient mechanically stable or not? Because certainly if they're not, then that pushes you more towards at least a surgical intervention to start, possibly followed by other things. And then finally, systemic disease. What's the systemic disease burden on the patient? Is this patient 7 years old with mets everywhere, very cachectic, not going to tolerate a surgical procedure, or are they young and relatively healthy and we can afford to be more aggressive with them? So key points of all this is spine tumors are oncological diseases first. We have to think of them that way. We have to ask the question, what's the extent of the disease? What's the life expectancy here? And I think most importantly, how is the patient going to be treated once we're done with them? Because if we don't think of that, then we're really, I think, not doing a good service to the patient. So I'm going to move on to a particularly complicated case that I took care of probably 4 or 5 years ago now. A 47-year-old gentleman presents with neck pain worsening for the last several months. No neurological symptoms whatsoever. Past medical history, otherwise a very healthy guy with a completely normal exam other than pain pretty much in any movement of his neck, I would say. Comes in with this scan. So again, we're talking in this case an epidural tumor that extends the spinal canal from about C2 down to the top of C4. Interestingly, there's some extension into the foramina both at C2-3, you can see in the top picture, as well as C3-4. And one thing to point out too, there's also this epidural disease anteriorly here, right in front of the cord. You can kind of see it on the axial images. It's just a sliver of disease that's anterior to the cord. So, what are my thoughts on this case? Is this a metastatic tumor? I don't really see any bony changes. CT scan didn't suggest it. It wasn't really something that it was high on my list, but could it be? Sure. It's been going on for a few months. Something like a schwannoma, it's coming out of the foramina. We typically see that with schwannomas, but if you looked at, I don't have the images here on the CT scan, there was no widening of the foramina that we would typically see. It doesn't look cystic in nature, that you'd think it'd be a more aggressive lesion. But it looks like a somewhat benign process overall, and yet I'm a bit worried with the appearance of the tumor and how much it's spread, what's really going on. So we elected to take him to surgery, both for diagnosis and what really is going on, but also for treatment. The goal of the surgery was really to decompress the cord. And my hope was to do that without necessarily compromising his structure, which is always a risk in some of these cases, particularly with the tumor extend out the foramina. I talked with the radiation oncologist ahead of time, not even knowing what this was. And given that at both levels, the tumor is basically encasing the vertebral artery, and it's pretty extensive extraspinal as it was intraspinal. We didn't think a gross total resection was really going to be a reasonable thing here. So the goal was really to try and decompress as much as possible, sort of sneak out the foramina, get as much of that tumor with then radiation to follow up pending the diagnosis. So took the patient to surgery. I think did a reasonable job of it. Did almost a hemilaminectomy to try and minimize disruption and prevent me from needing anything aggressive on the instrumentation front. Certainly debulked the canal. Was not happy with the amount that was left in the foramina, despite my fishing out tumor from the foramina at both levels. But it was respectable. We talked about him at tumor conference after the surgery, and radiation oncology was pretty happy to move forward. Turns out the diagnosis came back as an atypical grade 2 meningioma. So benign-ish disease, but grade 2, not your typical expectation. And the location was also kind of unusual because it was not intradural. I did actually open up the dura just to make sure there wasn't something else going on when the preliminary diagnosis came in. So 2 months post-op, the patient was slated to go for radiation, stereotactic radiation, and had this set of images taken just prior. And what was noted on these imaging, and a little bit concerning, is the tumor had, in those 2 months, started to regrow a fair bit. And so you can see more so on the axials. Actually, you can see on the sagittal too. So that sliver of tumor I'd shown you previously has actually expanded anterior to the cord. There's, again, a bit more fullness within the foramina, and even just lateral to the cord there. There's still not cord compression the way there was initially, but certainly worse than his immediate post-op film. So now we've got quick recurrence. Again, spoke to the oncologist. This idea of tumor separation surgery, because they were planning stereotactic, which allows for a higher dose of radiation in smaller fractions, they really wanted more room between the tumor and the cord. So they talked me into taking him back to surgery. I took him back and basically did a broader decompression. We decided, again, not to try and compromise the structure so that we wouldn't be putting instrumentation in. We did that. He tolerated the procedure well and went on to radiate. 6 months post-op, this is what his pictures look like after surgery, after radiation. He's now developed a pathological fracture within the bone of C2, as well as disease persisting and perhaps even worsening just behind the bone, as well as anterior to the spine itself. A year post-op, it looks even more invasive here. He's now got extension to the skull base. He actually developed metastases to the lungs. He's also developed a CSF leak as a result of the skull base tumor that had to be repaired by one of my cranial colleagues. 2 years post-op, he presents with worsening neck pain acutely and worsening neurological function. And now you can see a lot of progression despite multiple rounds of chemotherapy, as well as some additional skull-based radiation. Right at the skull base at the OC1-C2 junction, we got cord compromise, and he was actually taken by one of my colleagues for surgery, where he did decompression and occipital cervicothoracic fusion to try and stabilize across the area, because now the patient had gross instability on top of neurological compromise. Oh, I thought I had more pictures than that. I apologize. So he did that. The patient initially did well, but then developed a series of post-op complications. Wound dehiscence, because it was a previously irradiated field. He went on to continue to progress, and despite that, ultimately went into palliative care. And probably 3 years after the surgery, succumbed to his at that point grossly metastatic disease. So the lessons learned from this, again, is me trying to highlight the complexity of these patients. We're not just surgeons in this. We have tumor boards that sit every week There's the medical oncologist, the radiation oncologist, the surgeons are at those meetings, the radiologists are there to interpret films and sort of tweak some of the diagnosis potentially. We even have pain management come because sometimes they can offer interventional. And so it really takes a team of people to treat these patients. And I think that case really illustrates how complex it could be. You had two different spine surgeons. We had a skull-based surgeon involved from a surgical perspective. We had two different medical oncologists that were really trying almost everything to try and get this tumor at bay on top of the radiation oncologist. He did conventional radiation, he did some fractionated stereotactic radiation. So it really takes a lot of effort and a lot of thought to make the decisions along the way. That said, there have been a lot of advances in spinal neuro-oncology. So imaging is certainly more readily available. I appreciate less readily available in places like Ethiopia and other low and middle income countries. But hopefully with time, they are gradually becoming more accessible. Neuroimaging techniques will now allow us to see things that we couldn't see before, and that's an important thing. From a surgical perspective, back 20 years ago, stainless steel instrumentation was kind of the standard. Now we have titanium and even PEEK instrumentation, which will help with follow-up and following these patients for longer because we can see things that we couldn't see before because of the artifact. Separation surgery, which I talked about, taking the tumor away from the cord so that you can deliver bigger doses of radiation after surgery, is really become the standard of care. It wasn't even a concept 20 years ago. And we've got newer tools in our tool chest, embolization to help with vascular tumors like renal cell, kyphoplasties, vertebroplasties that can help provide some extra structural stability in some of these patients and pain control as a result. Radiation treatments are changing. SRS has now become often the standard of care. We're giving higher and higher doses of conventional radiation to treat some of the less aggressive tumors in an effort to keep them at bay, and we're having some modest success in things like osteosarcoma, osteochondromas. And then proton therapy is also becoming a thing, although still, I think, at its infancy. And as well, on the chemotherapeutic side, chemotherapeutics are being developed almost every day, it seems, with targeted agents. And that comes as a double-edged sword. They seem to be more effective at controlling systemic disease and visceral disease. And as a result, from a metastatic disease perspective, we're actually probably seeing patients live longer and therefore having more metastatic disease. So my suspicion is that with time, we are going to be treating more and more of these patients. Questions we always need to ask ourselves as we're treating these patients. First of all, does the patient need surgery, or is this something that we can treat without surgery? What's the goal of that surgery? Is it simply diagnosis? Is it treatment? But if it's treatment, what else is needed? It can't just be us for the most part. Again, there's some exceptions there, obviously, intradural schwannoma, you probably have a pretty good ability to cure the patient at the time of surgery, but we may not be able to. Is it palliation? Is it simply a pain procedure for the patient so that for whatever time they have left, they are in better their pain is better controlled? Can the patient even tolerate surgery? What's the right surgery for that patient? Is it a decompressive surgery with stabilization? Maybe in oligometastatic disease, does the patient actually need an en bloc resection? And then last of all, can we actually do that surgery? So I don't do en bloc resections. I think you need to have a skill set where it's done frequently in a center that it's done frequently at to be able to do that. Although I think there's some patients who would really benefit from that. And so if I have a patient who I think needs that type of surgery, I send it to someone else. So if I leave you with nothing else at the end of this talk, it's my final thoughts. So remember, even though we're spine surgeons, we really have to be oncologists first when we talk about this disease. We have to see the big picture. We can't just have a knee-jerk reaction and try and fix what's broken, because it's not that it's broken. There's a lot more complexity here. We have to know who to operate on, when to operate on. Is this a 3 a.m. case or is it a next week case? Because we need to work up further. What operation to do when we finally decide to do it. And then I think most importantly, what is next? And I think that's really something that for those of you on the call who work in LMICs need to reflect upon, because this is not a place where we can stand solo. We rely on other members of the team. You need to have oncologists on board. You need to have access to radiation in a lot of these tumors, particularly the metastatic diseases. Because if you don't, what you're doing is just putting a Band-Aid over an artery that's just gushing. You're not going to get ahead. You will give the patient, a few days, a few weeks, maybe a few months of reprieve from their symptoms, but it's going to come back with a vengeance. And at the end of the day, you have to reflect on their whole disease process before you decide exactly what you're going to do. So I'm sorry that the slides the quizzing didn't work out, but thank you for your time. And I've got a couple of extra cases we can talk through, or I'm happy to answer questions. Just by way of introduction, because none of my talks ever go without me introducing my two babies. This is Wilder on the left and Penfield on the right. My two pups that are named after the forefather of Canadian neurosurgery, because I, of course, am Canadian. It turns out I found Wilder Penfield is actually an American neurosurgery who we adopted in Canada. But regardless, these are my homage to my roots, so to speak. So thank you.
Thank you so much. Sahara, would you like to start some questions?
Thank you, Dr. Woodrow. It's very impressive presentation. I've learned a lot from this. I have a couple of questions pertaining to this. My first question is there any algorithm you follow for post-resection instrumentation in fusion? How is your threshold for fusion, and is there any criteria you use to decide which patients will need immediate or delayed fusion and which patients do not? And the other is on the Q&A section, some of the participants mentioned the role of preoperative embolization for the renal cell tumor metastasis. So what would you like to say a few points about the role of preoperative embolization, especially pertaining to renal cell carcinoma? Thank you.
Sure. No problem. So in terms of instrumentation, well, the first thing I have to consider is there structural instability, or am I going to cause structural instability by resecting whatever it is that I'm going to resect? So that to me is kind of the defining moment. I tend to be a bit more on the conservative side, as you saw with that second case, the second real case, where I think if you can avoid surgery, so in a case like that where I wasn't expecting the result that happened, if I can avoid the instrumentation, then we know it's a tumor that I'm going to have to follow down the road for an extended period of time. I think we're better off following them without. But if, for example, the bone quality, and that's not a good example for this, but if the bone quality wasn't looking so good, it looked structurally stable at the present time, but you can envision that as the tumor melts away, if the vertebral body is completely engrossed in tumor that you may not resect at that surgery, but that you can imagine as radiation hits that tumor and it melts away, then you're going to have a structural instability problem. Then I think it behooves us to do the radiation up the front end. What you have to remember, the instrumentation rather up the front end. What you have to remember is, again, what's the patient going to be doing in the future? Because if the patient's going to need radiation, and certainly most metastatic disease, we're going to give radiation, there's going to be a delay. And as you saw in my second case, in that time frame, the tumor expands and things get worse. But in that delay, if you don't delay, then you're going to be putting the patient at increased risk of wound dehiscence problems, which has become a bit of an issue. Now, we have some salvage procedures nowadays. If a patient comes back with wound dehiscence, we're turning muscle flaps, and they're becoming more common to try and prevent that secondary problem. But I don't think the clear-cut case is if there's structural instability, where I think is the big gray area is if there's no clear present structural stability, in which patients do you put in that instrumentation in? And like I said, I think there's varying degrees of gray there. I tend to be a bit more conservative on that, and okay, well, if they break down in the future, I'll deal with it in the future. But there certainly are centers out there, the MD Andersons, the big cancer centers, where I think they're being more aggressive off the front end, and I'm not sure we really know the answer to that. In terms of pre-op embolization, again, I think the key is kind of what you hinted at, which is the pathology there. So in that case where it's a renal cell, we know renal cell is a very vascular tumor. And if I'm only planning on doing a little bit of decompression, then it's less of an issue. If it's an emergency procedure in the middle of the night because the patient's rapidly declining and we got to get them to surgery, we don't have time to do that. But I think certainly in those tumors where you're envisioning a slightly bigger surgery and you have access to that technology, I think it's a valuable tool. But I'd say it's been rare in my practice that I've done it just between timing and availability of the resources to do it.
Okay, thank you, Dr. Sarah. We have another question from a participant from Shah. He said, with the large cervical meningioma, could you have considered a simple biopsy and radiation and follow with serial imaging? That's his question.
Well, yeah, so I don't think I would have considered serial biopsy. I mean, the patient had cord compression. It was a meningioma, right? And then whatever it was, you know, I guess if you thought, could it have been a lymphoma and then do a biopsy and then radiate? But I think as soon as you got the biopsy to say it was meningioma, I think surgery is indicated because it's not something that was a lower grade. It probably would not have been terribly radiosensitive as most lower grade tumors are. So I think surgery was definitely in the works there. Did I call it right? I think I did, obviously. Would I have done anything different is always an interesting question that we ask ourselves as we try and learn from our own experiences. You know, should I have been more aggressive at the front end? Should I have gone and done like embolized the vertebral artery on that side and really gone out of the foramen, completely stripped it down, put in instrumentation up the front end to be overly aggressive? I think I did the right thing at the right time, even in retrospect, because there was so much tumor there that was going anterior to the cord. I never would have gotten it all. It would have come back with a vengeance. It clearly did, because it really destroyed this man's occipital cervical junction, the skull base at the end. So I think if you'd done a biopsy and seen that it was a meningioma, which is not a bad thought, I still would have gone back and done exactly what I did for the surgery.
Sarah, could I rephrase the question a little bit for the people with more limited radiology than we might have? What are the clues you want them to be thinking about to make them think, hey, this particular tumor may be extremely radiosensitive? What would they be looking for to say this is myeloma, this is lymphoma? What are the clues clinically or radiographically, especially with the maybe CT scan? They may not have an MRI. It would lead them to say biopsy.
Yeah, I mean, a lot of those, you know, sometimes you're looking at their lytic lesions versus not can sometimes be helpful. You know, if you've got more benign lesions, they can, you know, you can get some radiographic changes there that are not lytic, so you can get expansion of the foramen and stuff. Or even scalloping of the bodies and things that are more benign. That's not necessarily, to your point, myeloma or lymphoma. In myeloma, you're going to see multiple levels of involvement, and that might give you a clue there as well. And then likewise, if doing a metastatic workup on a patient, if you've got the luxury of some time to see if there's lesions everywhere and you find out there's actually nothing, this is the only disease, and again points you into that pathway. You know, with multiple myeloma, you have serum markers as well. That's, again, depending on resources and availability in your environments, may give you a clue as to what's going on.
Thank you. Thank you. Saha, do you have another question? You're muted.
Sorry, so we have another question from Oyulie. He's asking if there is if you would like to say some things about the role of immunotherapy on this kind of lesions.
Oh, that's a load. That's a huge 2-day talk almost all into itself. I think nowadays the whole field of chemotherapy, immunotherapy is rapidly evolving, truthfully. And I'm gonna say I become a bit of a simple surgeon. I find it hard to keep up with the latest and greatest on those. But certainly, again, with any tumor, You've got adjuvant chemotherapy, you've got adjuvant radiation therapy. So there definitely is a role in all of these things. It's very specific to the tumor type and histology at the end of the day.
Okay, thank you, Dr. So maybe one last question. You actually addressed this. Is just to mention, how long after pre-embolization should the patient be operated? That's the last question from Louis.
So my answer to that is very quickly for a couple of reasons. So what happens when you embolize a tumor? What's the goal of it? Is to cut off the blood supply. What happens when you cut off the blood supply? It dies. What happens when tissue dies? It becomes necrotic and swells. So if you embolize today with the plan to take the patient to surgery tomorrow, in that time, tumors are going to swell. And if you've got compromise of neurological structures already, it's going to get worse with that time. So that's issue number one. Issue number two, depending on the agent you use, sometimes there can be, if it's very delayed, there can be recannulization, we know, depending on the embolic agent. So for those reasons, it's a rapidly planned process from my perspective. If you're going to embolize, then you embolize, the patient goes under anesthesia for the embolization, and then goes direct to the OR literally immediately afterwards to take care of things.
Mhm. Sarah, would you like to show that one more case that you have?
Sure. Give me a second to. So third case, this is a 39-year-old woman who presents with low back pain and pain shooting down her legs for many months. Her exam is fairly benign, normal sensation. She kind of has some mild weakness throughout, but again, it seems to be more pain related than necessarily functionally a neurological deficit. Past medical history is unremarkable. And comes in with this lesion. So here we have an intradural lesion. That's actually at the level of L2 is sitting right here. So it extends from sort of halfway through L1 down to L3 roughly. You can see it takes up a fair amount, almost all of the canal there. It does enhance relatively homogeneously. And so it's a lesion that's basically isolated around the conus region. Things that come to mind. No, I'll put Sahara on the spot since you're the only one that can respond to me right now, or maybe people can put in the chat as well what they think this lesion may be.
For me, it looks like myxopapillary ependymoma.
Yeah, absolutely. So that's certainly that's the top three in my diagnosis. Could it be something like a schwannoma or meningioma, just in this location? It could be that they're all intradural lesions that look similarly, but I agree. I would put that at the top of my differential. What concerns me about this particular set of images that we have is you see the nice bottom end of the sausage here, but the top end looks a little bit more pacified. It doesn't really look like there's a clear plane there necessarily. Is it how attached is it in that region? Is it infiltrating into the conus? That certainly is a concern. Okay. Again, I can't. Okay. So I took this patient for surgery. Myxopapillary ependymomas, as we know in general, are benign lesions. If you can, take the tail of if you can take the phylum and take the tumor out on growth as an en bloc resection, that's the best thing for the patient. We know that if you don't do that and tumor cells escape, there certainly can be reoccurrence. The handful of these that I've done over the years have been, I think, nice, gratifying cases because of that. This particular case, however, was not. I use the phrase that as I entered the dura, it kind of looked like a bomb had exploded in there. In other words, all I saw was tumor everywhere and nerve roots running through the tumor. Couldn't find good plane, found a good plane inferiorly, but certainly not at the top end of the tumor. And ended up doing what I label as essentially a glorified biopsy. So took as much of the tumor as I could and took, good chunks of tumor out. But as the tumor encroached on the nerves and completely engulfed the nerves, I sat there picking away. Literally, it felt like for minutes, but probably was for a few hours, picking away cells of tumor from individual nerve roots to try and maximize at least the decompression, knowing at this point the cat was out of the bag, so to speak, that the tumor had the tumor cells were technically infiltrating the CSF and could therefore seed anywhere. Ended up doing a neuroplasty on the patient as well. Again, not from an actual treatment perspective, but just to give her more room for her thecal sac, and knowing that I hadn't done a great job, nor could I do a great job in this setting. Fortunately, the patient woke up well. She was actually a fair bit improved post-operatively, and remained so for a while. She underwent conventional radiation following the surgery, and I followed her for about 3 or 4 years. This is when I was back in Kansas City, so I don't know what's gone on with her in the long term. I do know that for the first year or two, she had pretty good tumor control, but that the last time I saw her, the tumor did look like it was getting bigger again, which is not surprising given the pathology. So not a particular satisfying case on what we typically think as a low-grade, benign, theoretically resectable tumor, but I think from my perspective, in terms of the teaching perspectives of this case, again, what is the goal of surgery? Well, if you say myxopapillary ependymoma, I usually go into the surgery with the goal of cure, essentially. If you could keep that capsule intact, prevent any cells from escaping, cut the phylum, take the whole tumor out in one go, then the chance of recurrence is exceedingly low. Although you still need to monitor the patient, because inevitably, if you've poked the capsule and a random cell has escaped, it will come back. And the other thing I think is important with these cases is be prepared to pivot. You go in with this one-sided kind of, this is what the plan is. I have to admit, my style of operating, obviously, and those of you who've worked with me in Ethiopia probably heard me say this before, I usually go in with a plan A, a plan B, and plan C. I try and whether it's a trauma case or a tumor case, I have the way I want it to go in my mind, and ideally will go, and then the reality of, okay, if I'm not getting this tumor out, what are we going to do? Well, the goal then became in surgery to switch gears to say, okay, well, let's try and get as much of it as we can so that from a quality of life perspective, she will have the best quality of life for the longest period of time, knowing I haven't gotten it all, and that radiation is probably not going to be terribly effective in the long run. And at the end of the day, sticking by the medical mantra, do no harm. So, at some point, you have to decide when you're going to abort the procedure, when it's getting to be too much. And you have to be very conscious of that, not trying to go after that last little bit, because usually that's usually, I find, when you make the mistakes. So you've been in surgery a long time, you're struggling with the last little bit, and you want to get, you're done, you want to get the patient off the table because there's been too much blood loss, or it's just been 6 hours under a microscope and you can't do any more. And that's when you really have to take a deep breath and try and get that last bit out if you think you can, or decide to abort like I did in this case once I realized I couldn't.
Excellent, excellent. I really want to thank several people today for what's been an outstanding virtual visiting professor. Obviously, Sahar, I want to thank you for your moderation, for your introduction, and for helping us to make that link between the professors and the fellows and former fellows. I really want to thank Dr. Woodrow for taking the time. And this is something she's done throughout her entire career, to teach and to try to leave the world a little bit better than she found it. And that's very admirable. Her work in Ethiopia is superb. It will continue this May on the 7th and 8th when she will lead a boot camp there. We will do everything possible to make sure we record the important educational components, just as we have recorded this virtual visiting professor. I want to thank Jack Rock, who now heads our postgraduate education committee, because all these visiting professor webinars will be kept on our website for your continuing education. I'd like to thank Jeannie Bray, who's our administrator for FEANS, who's really made this all possible. But most of all, I want to thank you, the participants, our postgraduate education trainees, our former fellows who now are becoming our attendings throughout the world, for your impact. and for your desire to continue your education here and every day. So, Sahara, thanks so very much for your participation here. Sarah, thank you for everything you've done. And I want to thank everyone who participates to take care of patients worldwide in a very difficult time. This is a difficult time for the world, and we must be the people that see the right path to provide care for people where there was none before. That will be our moral compass. So thank you all so very, very much. We hope to see you in a continuing educational offerings, and please keep track of our website and our newsletters to see when those will take place. Thanks so very much. Thank you.
Thanks, Dr. Dempsey.
Thank you, Sarah.
And
Delightful.
looking forward to my
Thank you.
Ethiopian colleagues who may be on the call, who I'm seeing in the next couple of months.
Okay, that will be wonderful. Thanks now.